Great. So good morning, everybody. Thank you for joining Monty Heartcast Conference. It's again an honor and pleasure to have a really good friend, Nicolas van Mieghem, who's the Director of Interventional Cardiology at the Arteriotomy Center, and really a true expert in large bore closure. So Nick, we're all looking forward to hearing your insights into, what's changing, what's new in this important field.
Thank you very much, Azim, and it's a true honor and pleasure to be part of this CAT conference of the Montefiore Heart Center, and I think you've proven how successful a move to the United States can be, coming from one of the well-known centers in Italy, from San Raffaele now to Montefiore. I think you only got better, so congratulations for that. So here we go. In the next 20 to 30 minutes, I will discuss updated insights in large bore arteriotomy closure. I do have some conflicts. And let's start with an introduction to set the stage. And this is a recent meta-analysis that we published last year in Structural Heart, where we looked at all the data on large bore arteriotomy access with independent event adjudication. And I think this is important because if it is self-reporting, we all know that there is a lot of bias in what we report, what kind of data is being reported. So the independent adjudication is an important aspect and an important facet of this publication. And what was clear was, on the left-hand side, it relates to large bore arteriotomy above 16 French, on the right-hand side, 16 French or below. And if you then look at the aggregate, then the vascular complication rate, the major vascular complication rate for more than 16 French arteriotomies was 8.4% versus 5.5% with arteriotomies less than 16 French. So this means that French size counts. And this was an important finding, I think, of this meta-analysis. On the left-hand side in this slide, you can see that major vascular complications are still present in recent randomized trials, whether it is in intermediate risk or in low risk. And there was one outlier, that was the Partner 3 trial that had a major vascular complication rate of less than 3%. But in all the other trials, you see a vascular complication rate of 5% or above, a major vascular complication rate. We know from the pragmatic registry that was on earlier experience data that the majority of the major vascular complications, that was then as high as 13%, but the majority, 2/3, was due to closure device failure. So basically, percutaneous closure device failure is an important cause of major vascular complications. What are the percutaneous large bore arteriotomy closure techniques that are commercially available at this day and age? Well, from left to right, you see suture-based, plug-based, and then Percuseal and InSeal. But the Percuseal and InSeal technology, I think at this point in time, they're not as developed as they want to be, and they're not. They do not have a full-blown commercial launch. So let's focus on suture-based and plug-based closure with the Monta system. First, suture-based closure, and it is quite intriguing that there is no prospective randomized controlled data evaluating suture-based closure for large bore arteriotomy. I think these are two papers that were presented and published in 2015 that are of interest. On the left-hand side, you see the data from Catania, from Corrado Tamborino and his group. On the right-hand side, you see the data from the control registry. Control registry was a multi-center study, retrospective study, that also included the Catania group, by the way, and presented their data in the European Heart Journal. What you can see in Catania is that the outcome or the complication rate with two ProGlides was higher than with a ProStar device. Whereas in the multi-center data set, this was the opposite. Major vascular complications were significantly higher in the ProStar cohort versus the ProGlide cohort. I think this means that as a center, as an institution, but also as an operator, you need to become an expert in either one of the two technologies. And I think for the time being, ProStar is leaving the market, so we all have to start to rely on the suture-based closure with ProGlides. I think what is also of interest from that publication of the control study was that there was a need for covered stents in 5% of the cases, so 5% of the ProStar cohort and 5% of the ProGlide cohort. And there was also a need for urgent vascular surgery in up to 3% of the cases. And if then they looked at predictors for vascular complications, female gender is a consistent predictor that pops out in most of the trials. So let's move on then to prospective registry data. Prospective studies are limited, believe it or not, to the most recent closure device, dedicated large bore closure device, and that is the Monta system. And Monta is a plug-based closure that we are all familiar with now. It is commercially available in Europe and also in the United States. And let's start with the Ide Trials. You have the CE Mark trial and the Ide trial. The CE Mark trial was a trial that I did together with Azim here in Europe, so in San Raffaele and in 2 centers in the Netherlands, where the operators were basically non-experienced with the technology. 50 patients were included. There was only 1 major vascular complication. So that was already a hint towards the ease of use of the Monta closure device. On the right-hand side, you see then the Ide trial, 263 patients from 20 sites, highly selected in my opinion, and they ended up with 4% major vascular complication rate. This was published by David Wood, and David Wood was my co-fellow when I was doing my fellowship in New York almost 12 years ago. So it's fun to see that the fellows that you trained with are following you, and you are following them along the way. So that's very nice to see. But that said, we had these 2 IDE studies. So there was a need for a post-market study to see whether the data from these more selected trials could be reproduced in everyday practice. And this is what Marvel wanted to achieve and to study. 500 patients from 10 sites in Europe and Canada. Patients were 80 years old. STS score was 3%. Operators were somewhat experienced, so they had to have at least 10 Monta cases under their belt before entering the study. And the safety endpoints were a primary and a secondary. The primary was the VARC2 major vascular complications, and that was reached in 4%, minor vascular complications in 5.8%. But basically, any vascular complication rate was below 10%, so single-digit vascular complication rates, which is quite compelling if you compare that to the previous suture-based data. Bailouts, in terms of covered stenting, was required in 1.4% of the patients in Marvel, and vascular surgery in 2%. So this is numerically how it looked like. You can see on the y-axis the number of patients, and on the x-axis the kind of complication. And you can see that, for instance, major bleedings occurred in only 4 patients and resulted then in major access complications. What is interesting, I think, here is that 11 patients required surgery and 2 patients required a covered stent to deal with a major access complication. But sometimes you prevent a major access complication by using a covered stent earlier or by referring for minor surgery. But you can see that the number of complications are quite in perspective if you consider an overall number of 500 patients. So single-digit figures here for these complications. And the bailout maneuvers, again, surgery in 2.4%, covered stenting in 1.4%. So if we then collectively look at all these prospective studies, then you have the CE Mark study that was published in JACC Cardiovascular Interventions. You have the IDE trial published in SIRC Cardiovascular Interventions. And then there is the marvel that recently was published in CCI. So all are prospective studies, but all used or relied on independent clinical event adjudication. Again, I think this is a very important aspect if we discuss and talk about vascular complications. And we then pool these registry data in a patient-level meta-analysis. And it is important to bear in mind that the inclusion and exclusion criteria, and predominantly the exclusion criteria, were different for the 3 studies. And I highlighted here the important exclusion criteria for the CE mark study, which was, for instance, a complicated common femoral artery access. So basically, if you made your access and you are doing your procedure, you're doing your TAVR or your mechanical circulatory support, and at the end of the case, you see that there's a big hematoma, the patient was not allowed to enter the study. That's selection bias. In the Ide trial, they went even a step further. They wanted to have perfect punctures. If the puncture was not good, patient could not enter the study. This is, of course, different from a more real-life experience as we saw in the post-market study in Marvel, where those kind of more stringent exclusion criteria were not formulated. Still, if we pool all the data, we ended up with almost 900 patients, and the time to hemostasis was 31 seconds. The major vascular complication rate was 4.4%, minor vascular complication rate less than 5%. So again, vascular complication rates below 10%. And I think this is a powerful statement from the trial so far with Monta prospective studies, that the vascular complication rate is in the single-digit numbers. And we're not talking about majors, also including the minors. So this is quite compelling. And also important, there are hardly late vascular complications. So there was only one complication that occurred after 24 hours after the closure, which was a retroperitoneal hemorrhage at day 6. Overall, a bailout surgery or covered stenting in those 900 patients was required in 3.6% of the patients, and we get to that aspect later on. And what was of interest in the meta-analysis is that operator experience was not associated with access site complications. And this is something that we found in the study that is of interest. There is a phenotype. If a patient had a small artery that was laying deep, so if the arteriotomy was deep, but the size of the vessel was small, those were patients who ended up having vascular complications with the Monta closure. And this is what we call the FAB score, the arteriotomy depth and femoral artery phenotype. So if you have the combination of a deep puncture and a small artery, those are the patients who end up having dissections, stenoses, or occlusions, which is, of course, a very specific complication associated with a plug-based closure. If you do not have that kind of phenotype, then the vascular complication rate is much lower, and you can see that then you drop below 5%. So this was an important finding. Another interesting finding from the patient-level meta-analysis was that complications happened more often with a left femoral access as compared to a right femoral access. This is not so surprising because the reason to opt for a left femoral approach is, of course, when there is some kind of peripheral arterial disease and the operator would prefer the left femoral artery over the right femoral artery, because otherwise, in principle, I believe that a right femoral approach would be the preferred access site. So if for whatever reason, the operator would switch to a left femoral approach, that is already associated with more or with a higher risk of access complications, but of course there is some confounding there. And then, consistent with previous literature, the complication rate is higher in women as compared to men. Again, from the meta-analysis, we also looked at more than one predictor for vascular complications, and we ended up identifying female gender, then this phenotype, deep puncture in a small artery, and then the left femoral approach. So interesting set of predictors for vascular access site complications. So until now, we discussed retrospective and prospective registry data. There is one randomized trial, and that is the MESH-TAVI trial. This was a trial that included patients from Clinique Pasteur in Toulouse and also in Rotterdam here in Erasmus Medical Center. And we randomized 210 patients, 1-to-1, to either Monta closure or suture-based closure using 2 ProGlides. And that is important. So we compared Monta with 2 ProGlides. And then we looked at complications in hospital and out to 30 days. The inclusion criteria were broad. There were not so many exclusion criteria. And just to illustrate how the flowchart evolved over time, during the time window of the trial, we treated 350 patients with TAVR, because this was a TAVR focused trial, and 150 of those patients entered the study. So you might say, okay, that is selection bias. Well, not really, because the reason why we excluded the patients in the majority of cases was because they were enrolled in other studies or the patient refused. So basically, there were not so many patients excluded because of some kind of baseline characteristic. We did not have that granularity for the patients from Toulouse, but I think it illustrates that this was not a highly selected set of patients. The mean age was 81 years old, so a typical age of the patients that are currently being treated in Europe, and 50% female-male split, so that is relatively in balance. And what was also of interest is that almost 40% of the patients had at least moderate to severe or severe access calcification. So again, most of those patients would have been excluded from the IDE trial, but they were included in the randomized MESH trial. These were the systems, the device, the delivery systems, and then the transcatheter valve platforms that were used. So 1/3 of the patients received an Edwards SAPIEN 3, and then 50%, a little bit over 50% of the patients had an Evolut R or an Evolut Pro. This is the outcome data, basically on our primary endpoint of which was a composite of access site-related major and minor vascular complications. There was no statistically significant difference between the two cohorts, but we did see numerically something maybe. So we had 2 major vascular complications in the Monta cohort, 0 in the ProGlide arms, and the minor vascular complications. We had 8 minor vascular complications with Monta and 4 with 2 ProGlides. But basically, this could still be a play of chance. If you then look at the modified vascular closure device failure definition, which was the presence of any access site complications or the need for more than 5 minutes of manual compression or the need for additional closure devices, then the situation was different because the number of modified closure failures was double with 2 ProGlides versus Monta. But again, 2 ProGlides. So if an additional 3rd ProGlide was required, that was a modified closure device failure according to that definition. So on the right-hand side, you see the difference in access site complications between the 2 cohorts, not statistically significant. And then you see the difference in closure device failure, which occurs statistically more often with ProGlides. But was this clinically relevant? That's a different story. What was needed to deal with the closure device failure was also different between the two cohorts. In 50% of the Monta failures, manual compression, prolonged manual compression was enough, whereas in 85% of the cases of 2 ProGlide failures, an additional closure device was used. So this could be, from an economical point of view, this could add some perspective to the use for a Monta or ProGlides. And I think it is definitely noticeable that the need for endovascular stenting or vascular surgery was only required with Monta and was not used in the ProGlide cohort. So what were the device failures with 2 ProGlides? Well, it was, of course, a failed pre-closure when you were not able to install the pre-closure before the large bore sheet entered. Then a suture tear. We're all familiar, especially in these calcified vessels, if you want to close the suture, that you tear one of the sutures. And most of the time you can solve that then with an additional device. Sometimes you have incomplete approximation of the arteriotomy ridges. Sutures can also be approximated outside of the vessel wall, so in the subcutaneous tract, and of course then you will not have hemostasis. Additional closure, as mentioned, used in 34 patients, and there was no need for covered stent or vascular surgery. The reality was different for a Monta. It failed when there was incomplete apposition of the toggle and or the plug. At times you could have an occlusion of the artery by the toggle or by collagen. Collagen could also be wasted in the subcutaneous tract, so the collagen would not be able to be pushed down onto the arteriotomy side. And this resulted in the need for bailout surgery in a limited number of patients. So what were the limitations of the MASH trial? Even though it is a randomized trial, the sample size was restricted. It was not enough to look for meaningful subgroup analyses. And overall, there were only 14 vascular complications in the entire study. So we only had 7% of vascular complications. And I think this is a number that is really low, but it also attests to the experience with large bore arteriotomies in the 2 centers. I think an important limitation that has changed now in our practice is that during the MASH trial, we were not using systematic use of protamine at the end of the procedure for Montas. That is definitely now recommended, at least at my center. When we use a Monta, we will always upfront inject some protamine to neutralize the heparin. And there may have been an unbalanced overall experience with the 2 techniques. Of course, historically, most of the operators who participated in the study had more experience with the suture-based closure as compared with plug-based closure. But I think it also is worthwhile to stress the reality that any vascular complication of 4% in the suture-based arm, in the suture-based cohort, is strikingly low. It is so much lower than was presented in the control study in 2015, where the vascular complication rate was 20%. And it was also 15% in the Bravo 3 trial that looked at bivalirudin in TAVR, but also relied on suture-based closure in that study. So I think a lot of perspectives there to the outcome data of MASH. So what are additional takeaways from the experience and also from the data of these prospective trials? I think an important one is that ultrasound-guided access is basically the way to go. And you all, as operators who are embarking on large bore access, you need to be familiar with these images. You need to be able to use a linear probe and then create this longitudinal view of the bifurcation, and then switch to a short axis, and then you will see the profunda and superficial artery combine into the common femoral artery. And then I think you have a real-time view on your target, on the common femoral artery. It's not even time consuming anymore. And it also, at least in my center, no longer mandates the use of, for instance, micropunctures. I no longer use micropuncture because I'm sure I see the needle enter the vessel. So why would I need a puncture? I think the puncture location principle is a little bit different if you compare suture-based closure with a plug-based closure. We are all familiar with the region of interest between the epigastric artery and the femoral bifurcation. This is where you want to be when you obtain suture-based closure and for large bore access. But for Monta, it is a little bit more selective. You need to be 2 centimeters away from the femoral bifurcation just in order to make sure that the combination of the anchor and the collagen works best, and you limit the risk for a vascular complication. I think this is another important takeaway of the studies, that is, make a final angiogram after you did your large bore closure. Because sometimes you see that there is hemostasis, but that doesn't mean that there cannot be a problem. And what you see here is an obstructive dissection. There is a thrombus here. Here are, of course, this is incomplete hemostasis. But if you would not do a systematic analysis of your closure success, then you will miss this, and you will only diagnose the issue in the ICU or on the ward. And especially also in Erasmus, where we evolved towards lean TAVI, our patients no longer go to an ICU setting. They go back to their general ward after a TAVI procedure. So you don't want to have any surprises on the ward. So that's why we would always end a case with a final angiography of the femoral artery after closure. And if we do not have access anymore, then we would do an ultrasound assessment again to see whether the bifurcation is still patent after closure, and even you can demonstrate extravasation by ultrasound echo. A last slide on Monta failure and bailouts. This is data that we recently published also in CCI on non-randomized and data outside of a study protocol. These were just regular cases, and we combined 512 cases from Rotterdam. And this includes our early experience, and I think the experience that we have now is different from the experience we had three years ago when we started. And that is that we got better and better in understanding when there was incomplete hemostasis. In the beginning, that would trigger either the request for a surgeon or the implantation of a covered stent. Now we would rely more on prolonged manual compression. We would also use protamine earlier and more systematically. But at least in those 512 patients, we had a final angiogram in 81% of the cases. And no femoral angiogram, in 87%, and we had no femoral angiogram, 97%, and no angiogram in 3% of the cases. Of those patients with an immediate, with an angiogram at the end, we had an immediate angiographic success in 81%. In the others, we needed to do something else, and the bailout was either a prolonged balloon occlusion or, balloon occlusion or stenting or vascular surgery. But I can tell you that I can't remember the need for a vascular stent, so a covered stent, or a surgeon in the last 18 months in the Erasmus Medical Center for a Monta closure failure. And so we ended up with access site related vascular complications in 8% of the 512 patients, and the majority of those patients were treated with prolonged manual compression. So if you ask me then, okay, but when would you then use suture-based closure and when would you prefer plug-based closure? Well, I try to summarize a little bit how our practice is these days. I think we have 50-50 or 40-60% split of plug-based and suture-based closure. When protamine is allowed, then it doesn't matter. We use either suture or plug-based closure. There are instances where you would prefer not to use protamine. For instance, if you just did a high-risk PCI in a patient who was not pre-treated with DAPT upfront, so was only pre-treated in the cath lab and then was given heparin. Of course, at the end of the procedure, the DAPT is not yet at full force. I think there is a theoretical concern there if you would use protamine systematically. So those patients, we would not give protamine and we would rely on suture-based closure. When the case is done in a cath lab environment, then both systems work very well. If you anticipate to re-access early, that would be an argument in favor of suture-based closure, right? Because we have to bear in mind that if you have used plug-based closure, you can still get access at a site away from the plug-based closure site, and you can identify that by the stainless steel lock on fluoro. But if that margin, that region of interest is small, of course, you will not have that option. So I would recommend you then to consider suture-based closure. If there is heavy calcification, then my preference would be plug-based closure. Because with these, the more calcified the lesions are, the higher the likelihood that you would tear one of the sutures and that you would require additional closure devices, as was noticeable in the MASH trial. If patients are morbidly obese, I would be a little bit careful with Monta, because sometimes the collagen will end up in the subcutaneous tract and not on the arteriotomy side. In cachectic patients, it might be a similar situation where you will not be able to get the collagen through the skin because the patient is so thin. If the patient is in the ICU and needs or requires mechanical support for less than 3 days, I think you can use suture-based or plug-based closure. And if the patient is in the ICU and it is undetermined how long you will need mechanical support, for instance, ECMO, then I would rely on plug-based closure. And I know that this is off-label use, but when there is no, when we don't know how long a patient will need a mechanical support, then of course you don't want to have these sutures in the patient or these pre-closures in there for too long, because there is a theoretical concern of infection. And this is where we would then rely on a Monta closure of the access down the stretch, and then we would rely on ultrasound guided closure. And as you can see, you can identify the anchor nicely by ultrasound, and so you don't need the in that situation if you have a good ultrasound window. So with that, I would like to conclude and say that suture and plug-based closure for large bore arteriotomy is available in the United States and Europe. Monta is the best studied closure device for large bore arteriotomies. There's no question. We don't have the prospective data on suture-based closure. Complication rates are low for both plug and suture-based closure. And bailout options are fundamentally different, as I mentioned, and as was demonstrated in MASH. You need additional closure devices with suture-based techniques, but you can also then leverage the safety wire that is still in place. And covered stents or vascular surgery with plug-based technique is rare, but you still need those bailout maneuvers. And I think future larger studies may help us to further refine patient selection down the stretch. With that, I look forward to some questions. Thank you for your attention.
Thanks, Nicolas. That was excellent. I've asked, there were quite a few questions from some of the participants, well, two in particular. So I've actually asked them to ask their questions directly if they wanted to. So Dimitri and Mohammed, if you're willing to, you can turn on your mics and cameras and ask your questions directly, or otherwise I'll ask it for you. And then we also have a couple of friends, Matthias and a couple of the fellows who I've asked to join and ask some questions as well. So I'm going to see if any of them have any questions to ask. In the meantime, Mark Manigas, who works with me, is asking about this phenotype you mentioned, which I think it really is great that we start looking at phenotypes of patients who may do better with one device versus the other. And he asks, he says he worries about patients with almost no soft tissue above the artery. So these very thin patients where you see the artery very superficial on ultrasound. Do you have any preference there, Nicolas?
Yeah. So that was my next slide, where I tried to summarize my preference for which patient phenotype. And in the cachectic patient, I would prefer suture-based closure over plug-based closure. And I think the issue there is that in these very thin patients, you might not have enough space for the collagen to be pushed on the arteriotomy. So, and I think with suture-based closure, yeah, the fact that there is hardly cutaneous tissue doesn't affect the success rate, at least in my opinion.
All right. Theo Manaf, do you have some questions?
Yeah, hi. Good morning. Thank you for the presentation. It was actually very useful. Especially now, more and more we're doing large bore accesses and procedures requiring pellets and these devices. First, from the fellows' point of view, one question I have is that how do you train your fellows to get familiar with these devices, considering that these procedures there's high risk of complications. You want to avoid the complications. How do you put your fellows to the training? What's your approach for the training of your fellows?
Yeah, I think that's a very good question, and I think both suture-based and plug-based closure lean themselves to training. I think what we have set up is a margin of error, so to speak. So we can always correct if something is going wrong. And so we insist on ultrasound guided access. We insist on this final angiogram. And by doing that, you monitor almost every step of large bore access. And we typically train our fellows. First, they need to get used to the series of events, so to speak. So they need to familiarize themselves with the ultrasound approach. They need to familiarize themselves with the interpretation of the angios. And that is a very steep learning curve, right? It goes very fast. So basically, fellows are able to get access, a large bore access, at a very early stage in their fellowship because we can correct when needed. So you can anticipate, and you can also evaluate their techniques of using suture or plug-based closure, because technique is important. You need to get used to for instance, the amount of pull that you should apply with a Monta. You should be you should familiarize yourself with the tempering maneuver. It's not very complicated, but you need to get some sense of it. I think both technologies are relatively, again, easy to learn, and it's again also very easy to monitor each step of the procedure. Yeah.
Nicolas, I think you mentioned two really important points that we've kind of, even here at Monty, we've made it standard of care. The one is that, all femoral access should be done ultrasound guidance. We've now made that standard of care for every femoral access. But also, I think the other point you mentioned of doing a final angiogram, right? At the end of whether you're doing TAVR or you're doing impeller, whenever you do large bore access, to be able to do a final angiogram is extremely important, because a lot of these complications, if you identify them early, are fairly easily manageable in the cath lab. The problem is when you send the patient out of the cath lab with an occluded artery or with, still bleeding and you don't know about it, that's when you run into trouble.
Yeah, and I think the setting is so important. If something happens in the cath lab, it's a different animal than when the complication is diagnosed in the ICU setting. I mean, most of the time there's so many more people in the room in the ICU. There's so much more drama. It's so much more difficult to keep control of the situation. In the cath lab, you have full control in principle. So that's one of the arguments to double check the success of your closure before the patient leaves the cath lab.
Yeah, absolutely. Manaf, I saw you had a question.
Thank you, Dr. Van Mieghem. That was an excellent talk. Very usable information. Fellows. quick technical question and then a follow-up. When you are placing your closes, I've just noticed that different operatives have done this different ways. So I'm just curious what your approach is when you're, placing them at 10 and 2 at the, to cross the sutures. Do you first pull back, make contact with the artery, and then turn the ProGlide, or do you turn first and pull back? And the follow-up question was about the relative learning curves of the Manta and the ProGlide. Do you think that one takes a little bit longer to sort of get the feel down than the other?
Yeah, I think the good question. So the sound was not always optimal, but if for ProGlides, I would go in the vessel and then move to 10 o'clock and then move for the two different ProGlides. I think the learning curve is steepest. It's easier to learn a plug, I think. What I see from, and that is not my personal experience. When I was a fellow, there was only ProGlides or ProStar for large bore closure. But what I see from the fellows here in Erasmus is that the Monta, they really are. It's so easy because we're all used to AngioSeal. That is very easy to apply. Suture-based closure, there are more maneuvers that you need to do, and the more handlings that you need to do, the more there is more margin for error, I think. But I would never. But I would urge you, also the young fellows, to try and learn both techniques in parallel, because it's really true that in some patients you would get better results systematically with a Monta, and in other patients, sutures would be the better option. So I would definitely train in parallel both techniques.
Yeah.
And a safety wire from a different access in your large bore access vessel, or do you do that in some selected patients, or not?
Yeah. That's a good question. So we never use a safety wire. When I do transaxillary, completely percutaneous transaxillary, I do have a occlusion balloon in place for sutures. And I no longer use Montas for transaxillary closure. For femoral closure, in principle, the dominant approach is now a single access site. So that means that we would either use only the right femoral or only the left femoral, no longer both femorals. We use the right radial for cerebral embolic protection because that is one of our trademarks, so to speak, of the center. We want to protect the brain in almost all our patients, if possible. And then we would have one catheter, a 6 French braided sheath in the superficial femoral artery, and then the large bore in the common femoral artery, provided that the vessel size can accommodate two catheters. But this is the case in 80% of the patients that we treat in the Netherlands. So then it becomes very easy. If there is incomplete closure or there is an occlusion, you have access from the superficial artery. When we do not have that, we would always have a crossover from the opposite femoral artery or from the radial, but we would never have a wire distal of the closure site. We never do that.
Right. Thanks, Manav. So Manav's asking, obviously, me having trained in Milano, so there's still a couple of centers who we like the safety wire particularly for training fellows. I think if I had no more fellows in the cath lab, I wouldn't put a safety wire anymore. But since we train fellows, both us in Colombia still use a safety wire. But like I said, I think it's, a lot of centers like you, who's very experienced, have moved away from it and have great outcomes. So it's probably just a question of style more than anything else.
So Aziz,
Yeah.
So I think question to you, do you use the single access, so a catheter, so a sheath in the superficial and a sheath in the common femoral? Do you do that sometimes?
I do it only sometimes. I don't do it routinely. So if I see it's very tortuous vessels, then I do it. We tend to have our secondary access from the left radial. So we're also doing cerebral protection in most of our patients, like you. And then our pigtail goes from the left radial.
Yeah. So the reason why we opted to do a single access femoral access side, is that, you know, what you're doing is, so two radials, left and right. Yeah, in principle, then the patient is somewhat, immobilized to a certain extent for a couple of hours, right? I mean, you have to be sure that your arteriotomy closes, your radial arteriotomy. And we would also opt not to use bifemoral access, because then, you know, if you only use the right femoral and not bifemoral, the patient is more, can move better. It's easier to maneuver around for the patient. So I think we started using the single femoral access approach, so with a superficial and common femoral artery use, I think 1.5 years ago or 2 years ago now, following the paper by Samir Kapadia and his group in JACC Cardiovascular Interventions, where he looked into, I think 500 patients or so, or 250, I don't know anymore by heart. But anyway, he had very good results, and especially there was no increase in complications. The numbers were too low to make statistically significant differences between a traditional approach or the single access side. But I think in my experience, it is really a transition to super lean TAVI. It goes super fast now.
Yeah. Right. Yeah, and it makes a lot of sense, because you're right there. So how far away from your common femoral puncture does the superficial need to be? Because otherwise your sheath interacts, right? If you need to put a balloon or something, you can get some interaction. So what's the distance between the two?
Yeah, I think the distance between, so what is easy. So what happens is sometimes you need a balloon occlusion, right, for incomplete hemostasis. And then what I do is I just insert a peripheral balloon through the 6 French sheath, and then you withdraw the sheath right at the arteriotomy. And then you have margin, you have plenty of space. If typically it's, I think 3 centimeters would be the average between the two puncture sites, 3 centimeters.
Great. Okay.
What I do is I rely on my ultrasound. So by ultrasound, I identify the bifurcation in the long axis, then in the short axis. Then I identify the epigastric artery, because that is, of course, that separates the retroperitoneal space, right? So if I'm able to do that, then I do a puncture just below the epigastric artery to stay out of the peritoneum. And then I maneuver back south. I identify where the superficial and the profunda align with each other and combine with each other. And then I go a little bit more distal. And if I'm away from the bifurcation, that will be my puncture site. And in principle, it's 3 centimeters more or less from each other. But it's all ultrasound guided. And you will see if you follow the superficial artery, at one point it really enters the muscular part, and it's very difficult to follow. Well, you don't want to puncture there. And I also want to have a vessel size of at least 4 millimeters, because I do my closure with a ProGlide in the superficial artery.
And so correct me if I'm wrong, because I sometimes get criticized by my fellows about this, because I use ultrasound guided access as well. And majority of times I don't do a baseline angiogram, because I feel it doesn't add anything if I use ultrasound. Are you also not doing a baseline angiogram?
Yeah. That's so old school. Shouldn't do that. No, I think we have patients. You have the CT scan already, so you know what's happening around the aortofemoral aortoiliac bifurcation. That's one.
Mhm.
And then once you've become an expert on ultrasound guided access, you don't need an angiogram anymore. You just don't need it. It's a waste of time and it's a waste of radiation. Really is. And I think that the data from MASH illustrates that the vascular complication rates are becoming so low, and also Didier is not using angios up front.
All right. So let me ask. There was a question from Dimitri about MASH, and about sort of Monta versus ProGlide. And so, there are two questions that come out often. It's not just Dimitri who asks these questions. Many have asked. Is the one about cost effectiveness, right? I mean, Monta, if you look at MASH, it's shown to be equal. It's not superior. Yet the costs of Monta are significantly higher than two ProGlides. And then also, so that's the first question. Let me ask you that, and then I'll ask you the second question from Dimitri.
Yeah. So to answer the question on cost effectiveness, that's true if you compare again Monta with two ProGlides, but in MASH it was clear that in up to 40% of the cases you needed a third closure device. So then you have to compare Monta with three ProGlides or with two ProGlides and an 8 French angioseal. And I think then the pricing becomes, I think Monta in the United States still then would be a little bit more expensive. But then it becomes different, right? And the differences become smaller and smaller, I think. And it's fair to say that you will need more often additional bailouts with two ProGlides than with a Monta.
Right. Yeah, I mean, that's been the issue for us, is just cost, because it's significantly, it costs more than 4 ProGlides essentially for us, to use a Monta in America. They really priced it at a range where it's the challenge to justify using it on a regular basis. But anyway, so Dimitri also asked, and then we're going to move to Mohammed, who has a couple of questions, and hopefully we'll ask his questions directly. In a center who's only done ProGlide and now wants to introduce Monta, right? How do you suggest they do it? I mean, do they just start with very simple cases? Or do you just say, now you want to learn this, you're going to use it in every case?
Yeah, that's an interesting one. I would start in simple cases, and that is just to be realistic, because you need to get a feel of the device. And also, you need to learn when you have a Monta failure. And that doesn't mean that if there is no, so in the majority of cases, you will have close to immediate hemostasis with a Monta. But sometimes there is not immediate hemostasis. And then it is also important to stay cool and just hold manual compression, but it should not be occlusive compression. So those are the handlings that you need to learn. And I would say be a little bit experienced before you go into the more challenging anatomies. And make no mistake, when in these TAVR patients, they are elderly patients, they often have peripheral and ischemic heart disease, so you will have patients with more or less calcium. So I would not start with the FF3s, like the deep punctures in small vessels. I would not start there.
Okay, great. Mohammed, you had a couple of questions. Do you want to ask them?
Yeah, thank you so much, Dr. Latif, for the opportunity. Great presentation. Just have a few questions. First of all, was there any comparison from or maybe from your experience, comparing perclose with protamine? Because we started routinely giving protamine sulfate after TAVRs, and from my limited experience, I really noticed that it decreases your all these modified vascular, what fits modified vascular complication. So that's number one. Number two is, was there any comparison against a single perclose? And then the third question, I apologize, I have, because I have to run for the next patient. But as far as when you do a perclose for a calcified artery, how do you adjust your method of deployment? Do you do it 12-1, for example? Have you also seen Dr. Diri, where he actually pulled the plug multiple times, like up and down, before he, like rounded and cut the sutures? And I'm not sure, what's your experience on that?
Yeah. So did I use? Did we compare suture-based closure with and without systematic protamine? No, we did not. Mm-hmm. And I must say that we are less inclined to do that, because if there is still oozing, or it doesn't, and we still have that safety wire in, then the step towards an additional ProGlide or AngioSeal is very small. I think with Monta, you don't have the safety wire, so that is where I would prefer to use a more systematic protamine approach. Okay. I'm not aware of any comparative trials. I know in Australia, Dr. Walton is designing a trial to look just into that systematic use of protamine versus not systematic use of protamine. Nice. That's one. We did not compare Monta with one ProGlide. Bear in mind that 40% of the 2 ProGlide cohorts required an additional device. Mm-hmm. So I would not feel comfortable closing with one ProGlide. I know you can do it. I know you can close a 12 French with one ProGlide, but it will not be 100% success rate. I don't believe that. And yeah, my strategy is still, if it's beyond 10 French, it's going to be 2 ProGlides. 10 French and smaller, I close with one ProGlide if I would use ProGlides. And then the last question.
The per close for calcified arteries. Do you adjust your technique, and what's your take on doing 12-1 instead of 10-2?
Yeah, I always start with a 12-2 when I do my pre-closure. Mm-hmm. But sometimes you will see that you cannot deploy it, and that would be then the reason to change the strategy and change to a 12-4 or a 12-6. Or a 10-6 or 10-4. So there is some variation there, but I think as you are installing your pre-closure, you also get some tactile feedback of your tissue. Mm-hmm. And that is very important. So you have to learn to feel when the anchor reaches the arteriotomy, because in a lot of those cases, the anchor got stuck at calcium or at some kind of plaque, and this is where your pre-closure fails. So that is, I think, one of the things that you need to learn during your training. That is, learn how to feel when the anchor of the ProGlide reaches the arteriotomy.
Mm-hmm. Yeah, that's such an important point, Nick, for why we have failures, why we have back wall punctures, is getting that sensation of, you've come back and you're actually on the anterior wall of the arteriotomy rather than stuck in a piece of calcium. And it's also something that I have to admit, it's hard to teach because there's a little bit of tactile feel to it, and a number of times, it happens and you go, no, this doesn't feel right. I'm going to, close my foot plate, try and, reassess my depth and then start again, kind of thing. And I think, that extra attention really can decrease complications.
Yeah, and this is this component of tactile feedback, this concept, I think this is an important feature of interventional cardiology, and probably this is also, why, some become very good and some remain average interventionalists. That is something that you need to develop, and the more experienced you get, the higher the likelihood that you will be able to get that tactile feedback. Yeah,
right.
Very important.
So Nick, maybe last question from me. When you have to remove an impeller a few days after it was put in, it seems, what is your preferred approach? Are you using ProGlides to do post-closure, or are you doing Monta?
Yeah, I use an ultrasound guided Monta now.
Okay.
Yeah. But I think the ultrasound there is important again to identify the anchor. I find it difficult to rely on the arteriotomy depth if a impella has been indwelling for a couple of days, because there is subcutaneous oozing, and there might be some kind of a bleeding component to it, and that might affect, of course, the arteriotomy depth. So I feel more comfortable than using the ultrasound guided Monta closure. Pre-closure, yeah. If I anticipate that the mechanical support will be indwelling for less than 72 hours, you could still use, or we were using pre-closure, but I must say that we now converted to Monta closure.
Okay. Yeah, I think it'll be interesting also to see, I think both of us are involved with the Percutaneous studies. So it'll be interesting to see if that device can also, widen our armamentarium, particularly for post-closure in certain cases. So yeah. I think there's still a lot, it'll be still some interesting times and a lot to learn in this field still.
Absolutely. Yeah, absolutely.
Nick, thank you so much for taking an hour out of your day, especially on a busy clinic day. We really all learned so much from you. And I look to seeing you very soon, my friend.
It was such a great pleasure to be part of the Montefiore CAT conference. Thank you very much, Azim, for your friendship and for inviting me. Thank you. Good to hear you. And good to hear you all. Thank you.
Yeah. Thanks for joining us. Enjoy your day. Bye-bye.
Have a great one. Bye.